Hi, everybody. Thank you for joining us for this session on assessment in our Psychosis Informed Care series. We have an excellent lineup of presenters who bring deep expertise in clinical care, peer support, and research. Dr. Emily Carroll is a clinical psychologist specializing in early identification and intervention for psychosis and serious mental illness in teens and young adults. She is the clinical director of the STAR program and director of clinical assessments at the LEAP Center at McLean Hospital. Steve Fidel is a peer specialist and program coordinator of the Well Space program at McLean Hospital. He is passionate about supporting individuals in building meaningful lives. He is also a writer, researcher, and co-leader of the Peer Research Consortium, which advances research on peer work in clinical settings. Divya Kumar is an assistant in psychology at McLean's Behavioral Health Partial Hospital program. She co-directs the practicum training program and provides therapy and assessments for individuals with a range of clinical diagnoses, including psychosis spectrum disorders. We're thrilled to have them with us today and look forward to learning from their insights.
Thank you so much, Michelle, for that wonderful introduction. We can get started, and what a pleasure. Our aim for today is to increase your confidence and comfort by providing you information, helping you start to target stigma and potential biased thoughts, and providing you some specific skills for you to test out. And when we are talking today, our focus is really going to be on applying these skills the first time someone you're working with is potentially starting to share symptoms of psychosis or experiences of altered states.
This is a little bit of an outline of, just what we'll talk about today, different segments of the slides. So, the first segment is understanding psychosis or alternative experiences. There can be a lot of different ways to think about this and to, describe it. I think, one of the clinical ways might be psychosis, which is what we'll focus on a few different ways and a few different stories. But that's going to be one of the themes today, just to be aware of, like, multiple stories, multiple themes, and finding different ways to think about, people we're working with, which kind of leads into the segment we'll have on naming internal stigma and bias. So kind of naming, turning inwards and, we're all here together, growing and learning together. So, that's one of our goals, to keep that learning going. And just, from a clinical side and a peer side too, if you're a peer or any mental health provider, tips for building comfort and confidence in assessment, and then just being in that space too when you're meeting with someone, who's dealt with these experiences. And just so everyone knows, as a peer, I identify as having dealt with psychosis and having, had different diagnoses, and I look at it in all different ways. So we'll have an example assessment conversation, with we'll have some role plays, and then resources we'll share, and a question and answer. So thanks so much. We're grateful to be here, and we're looking forward to this. Thanks.
So we're going to jump in by thinking about how we can understand psychosis experiences from a collective perspective, and we will start with this.
Okay. So this is an experiential exercise that we're going to do, just to turn inwards. I think, this is not something we're going to, you don't have to post this to the chat or anything. This is just an individual thing, kind of like a turning inwards and checking, like, where am I at? How am I doing? So I think this exercise is just intended to quickly, with paper and pen or notepad on the computer, just get a sense of, like, how you're feeling. So we'll jump right into the exercise, I think.
Yeah.
Okay.
Thanks, Steve. Yeah, so we're gonna have a number of statements, and I want you to think internally without judgment, just what's the first thing that comes to mind as you read these statements and as we read them out loud to you. So the first thing What is the first thing that comes to mind when you think of symptoms of psychosis? It could be an image, a person you've worked with, something that you've seen, emotions. Just briefly think about that for yourself. And now for these next questions, we're actually going to rate your agreement. You can do this again internally or on a piece of paper like Steve mentioned. And we're going to read different statements and ask you on this scale from 1 to 5 how much you agree with these following statements and questions, where 1 is strongly disagree, all the way to 5 strongly agree.
Okay, so the first statement is people with psychosis are dangerous. So to just turn inwards and, think about this for a little bit. This is the statement. And our second statement is people with psychosis are unpredictable.
So next, I would make friends with someone who has or is experiencing psychosis. And then finally, I would marry someone who has or is experiencing psychosis. Just noticing for yourself what comes up as you think about these statements. This is modified from a longer scale that's been published in a number of different ways. And this is just meant to illustrate what we bring to the room when we're thinking about different symptom presentations that someone might be having, our own biases that go into when we're assessing different symptoms and the different ways that society influences these thoughts as well. So what came to mind as we were going through this is what you could potentially be bringing into the room when you're working with different individuals. And we want you to keep that in mind as we're going through the presentation today as a way to think about being more human-to-human interactions with individuals. So thank you for participating in that and having an open mind related to this. All right, so related to that, we're now going to move into some more discussions around how we can have a flexible view and definition of psychosis and altered states that will then relate to how we ask questions and how we are assessing psychosis.
Okay, so yeah, Chimamanda Ngozi Adichie, she's an author. She's written a few books at this point, and she's a human rights activist. And yeah, just want to talk about her TED Talk about the danger of a single story. So, as it pertains to mental health and psychosis, there can be singular stories. I think the interesting part of her TED Talk, she talks about having grown up in Africa and then immigrated to the United States, and just how that experience was. There were singular stories about her within the collective consciousness of the place she originally went to school. And, this can happen in multiple situations too. So from a mental health standpoint, we think about there are these singular stories that, the media can hold about psychotic disorders, like people are dangerous or people are doing violent things, or, all these things that we hear. And, there can be a lot of singular stories. So it's interesting to think from a clinical perspective, like what's the group that you're within, and like what are some of the singular stories with that? So sometimes this can be, a clinical understanding of a person as opposed to having a number of different understandings of a person, which is the point she's really trying to make, is that we all have so many stories to our narrative that comprise who we are. And it's so essential to understand people who come to you in a clinical setting, to think about like, who are they? What's their background? Why are they here? What are they experiencing? What's their life like? Where do they work? Who are their family and friends? Like, where are they from? Like all the different stories that comprise a person, their likes, their dislikes, their thoughts and beliefs. All this comes together when you're in the room meeting with someone, especially when, you might be seeing them for the first time, and this might be one of the first times they're newly experiencing psychosis or an altered state or an alternative experience, trying to keep a number of different narratives in our minds that like there are a number of different ways to look at the mental health condition, if someone even looks at it as a mental health condition. And for us to be accepting and understanding and wanting to understand everyone, of every orientation in a number of different ways. I think it goes beyond, the mental health. Obviously, there's so many things we're all collectively working on together. But just to think about that, if you catch yourself thinking in one particular way about people with psychosis or any group of people, to ask yourself, like, there's got to be a lot of different ways to understand someone. And this can be really essential because it helps us to come together and to, just learn more about each other and to, have that togetherness. So, yeah, and especially working in your clinical assessments, like, understanding who someone is, having genuine curiosity for who they are and what they've been through. So I'm just going to read this quote to sum up this slide. She states, many stories matter. Stories have been used to dispossess and to malign, but stories can also be used to empower and to humanize. Stories can break the dignity of a people, but stories can also repair that broken dignity. So this is an 18-minute TED Talk. It's brilliant and it's really powerful. So I could talk for a while on this, but we'll move forward. All right, and this is multiple perspectives of moving beyond the DSM. So kind of like transitioning into what we were saying, psychosis can be understood in a number of different ways. So I think, as a peer, I'm a peer specialist and also someone who's dealt with this for 18 years. I have my own experience, but I want to learn from everyone in the groups that I facilitate, all my individual meetings, right? Like there's just so much to learn from so many different people. So one way of describing psychosis, it's a state of mind and being that can be distressing, painful, confusing, and disorienting. There can be a lot of disruptions in your thoughts and perceptions. There are a lot of different elements to it. It can be really painful. You can get headaches. It can make it difficult to think clearly. For me, I dealt with delusions, which, there are different ways to look at them, like different beliefs or belief systems. There's different language to describe things. It's not necessarily a diagnosis, so, it can happen at any particular point in someone's life or even going through a distressing situation. There are the five senses, so someone might call this hallucination. It could just be an altered experience or perceptual experiences. So, every person's internal experiences are different. I think the major thing to understand is just to approach it with curiosity and to also approach it with there are thoughts and emotions, that it's not one singular thought and one singular emotion that's happening. There can be a lot of emotional pain. And in Dan Fisher's emotional CPR, he talks about how sometimes, we get in these clinical settings with the mind, the psychoanalysis, the cognitive. But if you're in that mentality too much, you can get detached from your emotions, and kind of bringing those spheres of influence together can be really powerful. What are someone's emotions? How do they feel? What's going on in their life are really important questions to be asking as you're understanding some phenomenological things that could be happening as a normal reaction to someone's life experiences. Yeah, so I think, yeah, we'll go to the next slide, I think. So it's good to be aware, this experience can be inhibiting in many ways, but every individual is going to be different. So there's no cookie cutter way. The thing I've come to learn as a peer when I'm working with people is to just ask people what's happening and to be receptive and let them tell me and not have to be the expert. So it's a normal reaction. We talked about that. It can coincide with a number of different things like depression, bipolar disorder, schizophrenia. Can also be a result of brain trauma, of seizure disorders, other conditions, sleep deprivation, isolation. Loneliness is a major theme for a lot of people when they're initially dealing with this, just to have that awareness. That's something important. And there are a number of different models to understand this. Throughout the years, I've had a great clinician who's helped me a ton, my doctor, who I go to therapy for. But I remember I understood psychosis in a number of different ways with different psychoanalytical models. And then I read The Body Keeps the Score, and I used it as a workbook, and I was like, huh, this relates to a lot of the trauma I've been through, and this gives me a completely different understanding, but it also makes a ton of sense. So this is another idea about the danger of a single story. Like, psychosis models aren't the only way to understand psychosis. There's peer models, there's just like life experience models, and like all these understandings can come together to paint a more complete picture. So I think the other thing to keep in mind is that sometimes it feels like it can alter a bit how you feel and how you talk and what you say. And, I know in my own experience, I had times where I said I don't feel like myself, but that was very hard to discern for other people. But that's just like a common experience to be aware of, that it affected me socially in terms of the things I said and did and how I felt. But that was very difficult for other people, clinicians, coworkers, people I work with, friends, to pick up on. So that might be something people commonly report that is not always as discernible. So, okay. Mhm. And yeah, I think, it brings us to this other point too of dialectics, that like, um, you know, there are a lot of workplace dialectics, and I think Hegel talks about dialectics, and Fitzgerald too, where it's like there are all these opposing thoughts and ideas, but to like hold them all at once. And I think the biggest thing is being aware of like what are our implicit messages. So I know sometimes it might be commonplace to say, oh man, it's Monday, like, right? That's a big American thing, like, oh, Monday morning, like, oh, here we go. But then like when you've dealt with a mental health condition, and you hear someone saying they're upset that it's Monday morning, like that's a major implicit message of like, I'm struggling and trying to keep myself alive, and this person is worried about being at work on Monday morning. I think, both can have some validity, but just to be aware of like, you know, what are the common things you're saying in the workplace that may be positive or negative implicit messages. There are spaces to hold that truth that like, yeah, like the work week can be tough, but also to keep in mind that like someone's really suffering and struggling. So that's just one instance of like a workplace dialectic. And when people are in clinics, they hear you say these things on the inpatient units, in the clinics, in the residents, and that can make or break like how an interaction goes and how like the care goes. So that's one of the many reasons. And we want everyone to do well and to feel good in their workplace. So that's another reason. We mention it for everyone.
Well, in this next section, we're gonna, Steve and I are both gonna share a little bit more about our different perspectives of being assessed, but also assessing psychosis, to then transition into some more of our tips and recommendations on how to create environments where you feel confident in assessing psychosis, and also bring a sense of safety and comfort to the person you're working with as well.
So I'm going to partly speak about my own lived experience and then just relate this to, the number of stories I've heard from other people. I've worked inpatient for about 6.5 years. I've worked residential, I've worked outpatient. So I'm just saying that because these are like the collection of stories I've heard from different levels of care. But so when I showed up to the hospital, I had just come out of my first episode of psychosis. I didn't know what had just happened. I had just lost all my friends. I just had a lot of phenomenological experiences, like for me, referential thinking, or it felt like the internal and the external were blended into this one world that felt really confusing. So, like, it was just a blend of things happening. It was really confusing. I was really distraught. I got tricked into going to the hospital. My parents told me they were taking me to a party. And so like I think it's just important to think about, there are a number of ways people will show up to your treatment center. It could be volitionally, it could be they were tricked into it, it could be they were restrained, it could be the police forcibly took them in and they were just scared or afraid. So I think just like keeping these possibilities in mind, that someone might have just came in under really duress circumstances. So I think another valuable thing is thinking about power dynamics. This is right at the center of trauma-informed care. As soon as someone walks in the door, And, you know, for me, like I wasn't thinking as clearly, I was dependent on the medical staff. There's a power dynamic when you're not in your best state of mind, and when there are rules and regulations and laws that allow for hospitalizations and other kind of like forms of care. So I think as a provider, like mitigating those power dynamics and creating as much equality, which you'll see a bit in the role plays, is really important, just because that's going to contribute to someone's fear. There is a high percentage of people who've dealt with trauma who have dealt with psychotic disorders as well. A lot of the times they go hand in hand, and the trauma is a part of the reason the phenomenology is happening and the other tough experiences. I think again, understanding of the language used, this goes beyond like human experience language and just using like everyday language and talking to people with equality. I think you know, I showed up, I was 22 years old, and the doctors were very learned. They were very, I'll say, erudite, or they had like a learned vocabulary. I didn't know half the things they were saying. And, you know, as a kid, you kind of learn to nod and like pretend like you know what someone's talking about, or at least I did at that age. Not everyone's different, but like people kind of like won't always tell you if they don't understand what you're saying. So using common language that's just understandable. You know, not everyone studies vocabulary all the time. There are all different types of intelligence. So I think just to like be aware that like, I know a lot of words through my work, but like I got to use words that are going to make sense to everyone. So I think I also was sitting in the room, the the meeting room, and the doctor told me, you have schizophrenia. And I was like, that doesn't make any sense, because all the stories I had heard about it were from pop culture. I was like, what are you talking about? Um, you know, and I think as well, just to keep in mind that the results of how we treat people and the experiences they have will sometimes determine if they're willing to come back for help or if they're not. So that's one outcome. I think another outcome is just to realize people can and do fully recover, and to always hold that hope in your heart and mind. So, okay,
Sorry, Steve, I clicked the next button too quickly.
that's okay. Yeah, all right.
So piggybacking off that, just sharing some my own experiences, thinking back to when I was, first working with individuals related to assessment, both from a clinical perspective, but then also doing research skids where you're asking these really structured standard questions as well. I had a lot of self-focus when I was doing this work in the beginning. Coming really from anxiety of, can I do this? I don't really know the right questions. This is the first time I might be asking these questions. Also the first time that maybe I was interacting with someone who had that level of symptom severity. And so really wanting to do a good job and feeling that pressure of, just like what Steve is saying, of wanting to approach this person with compassion and knowing that I wanted to help this person engage in care, and then almost freezing up with that responsibility. So really leaning in on kind of writing things down, looking at questions that I had written out before, trying to ask really specific questions to pinpoint what someone's experience was, so I could then tell my supervisor and then get, their feedback on it. So my experiences, and sometimes this can still come up for me, was that pressure, which very much feeds into focusing on myself versus the other person, not coming at it with a slower perspective and a humanizing perspective. And so that's my often kind of reaction to fear and unknown, and is something that, I've worked out for a long time. Steve has helped me in a lot of different ways, and thinking about how does my own anxiety and my own thoughts impact how I ask questions, and then connecting with that other person.
Think we've helped each other as well to understand a lot about all of this work, just to put that there. So yeah, our next segment will be tips for cultivating new relationships and approaches to common thoughts, bias, and stigma. So kind of like, okay, how do I look at this differently? And then how do I cultivate these relationships? Because like Emily said, it's like we all are here because we care for people and we want to figure out ways we can connect and like keep caring for them and keep finding ways to just be helpful to people. That's our work. That's what we all do. So that's our goal here. Okay.
So we've brainstormed. This is with Divya, who's going to join us in a moment for the role play and talking with each other on different experiences, common statements or thoughts that we've heard from a lot of different people and ourself have experienced. So common ones that I hear from trainees that I work with all the time is, I don't have the knowledge or experience to properly assess psychosis, to work with this person who's sitting in front of me naming these symptoms. I don't know what to do if a person says yes to a symptom of psychosis, or if they've shared symptoms that I've never heard before or I've never treated. So just think to yourself as we're reading through these, if any of these feel familiar to you as we're going through them as well. So our general advice here and thing to keep in mind is that individuals experiencing psychosis don't need to be approached any differently than anyone else who's coming through your door into your office, into your virtual room, asking you for help. They're an individual, they're a human having different experiences. And I say that to help take the pressure off of you. I named the pressure that I feel and, oh, I have to do this differently. You are all trained clinicians, no matter what your experience is, and you can utilize the skills and the experience that you already have and your life experience as well. So trying to think that you don't have to learn something new. And so helpful ways of thinking about that is helping yourself focus on assessing and asking questions around what is the experience like for them? What is going on for them? Like Steve said a little bit a few minutes ago, of just sitting with them and saying, how have you been? What is this like for you, to get a sense of the emotional experience of it? And then reminding yourself of all of the skills that you have to target and help someone with any emotional experience that they have, and thinking about using that skill set in the same moment. And then, just like we started out, thinking about how your own thoughts might be getting in the way of you utilizing the skill sets that you already have.
So this is our next slide. Similar theme. We have some statements which I'll read, and then we'll have some insights written out, and then I'll talk a bit. Same as Emily just did. So there's this idea of like, I have all the answers. I know more about psychosis than this individual does. I have to make decisions for this person. They can't make decisions for themselves. I know what's best for them. This person can't think clearly, and they can't benefit, like they need the skills I have. So yeah, we're going to talk about this a bit. And yeah, so I think this has been a theme of the day. Power dynamics. I think the other thing to be aware of is that when people perceive a power dynamic happening again, it can be re-traumatizing, and it can be a reiteration of trauma, and it can really shut down people's thoughts and emotions, which had been my own experience in different settings. And I've talked to a number of other people who've had the same experience, people with lived experience. So yeah, there can be this mentality that like we have to be the expert or the knowers, right? That's very Western. But I like the Eastern approach of like, I'm the beginner. I don't have to know everything, because I don't. And I think there is kind of that growth, at least that I've gained over the years. I remember coming in like, oh, I know so much. I've done so much writing, this and that. And, it's kind of a commonality, but it's like I continually learn how much I don't know over the years. And I've reached a point as a peer where, I've realized like I don't have to know everything. I literally just have to ask people. And if we have enough equality and they know I genuinely care for them, then they're gonna be telling me everything. And it becomes very easy as a peer to just say like, like I think the thing I've learned to cultivate is like the empathy and the kindness and the love for every person, to be like, no matter who comes through the door, no matter what they've been through, what they've done wrong or right, or what's been done to them, like it's like to just care for them, to really care for them, and just to fully understand that person as the full human they are. So, asking questions about person's experiences, realizing that they know themselves better than we could ever know them. And like, we don't need to know everything. It's about what they're thinking and they're feeling and kind of, having that flexibility and adjustability in the conversation to talk about the thing they want to. In open dialogue, we talk about like listening without an agenda from the Finnish, dialogic practice that's been adapted to the US and other places. It's like listen without an agenda, come in without an agenda. What's this person want to talk about? Like just being open to talking about whatever they want to. And yeah, so, and I think as well, the clinical elements too, and this is all clinical too. We're all we have a lot of overlapping stuff. I think, asking someone if they want strategies. As a peer, I actually hear a lot of people, not everyone, but like sometimes people are like, oh, I don't want the clinical side. But I'm like, it's helpful to know the diagnosis. It's helpful to know the strategies. There are more tools, there are more resources. I think it all is helpful and the peer modality is helpful, but I remember telling a few people in a group, I was like, I like knowing the diagnostic terms, not because I always identify with them, but there's like literature and articles and reading on them that have helped me to like learn and give me insight into what I'm going through and to like work through it. So like it all comes from all different vantage points. And again, multiple stories, multiple ways of understanding like that. That's where we're at. Um,
Other statements that we often hear or, have had ourselves is, I'm afraid of psychosis. Is this person dangerous? Is this person violent? That's what we hear a lot in the media. So some stats that we wanted to walk you through that individuals with serious mental illness are often more likely to be victims of violence than perpetrators of it. And that, a lot of the stats show that there are same rates that we see in the general population compared to individuals with serious mental illness. And I think an important thing to remember is that the individual themselves, the person that you're sitting with, might often be scared or confused about what's happening to them specifically. So knowing that fear and confusion is there will also help you think about how you're asking the questions and interacting with them. And then, Steve mentioned a couple times trauma-informed care. It's really important to be thinking about that always. The experience of psychosis themselves, many people describe it as a trauma experience, and there can be a lot of other traumatic experiences that that happen to people in their lives as well. So keeping that open mind when you never know what that person has gone through, what they've gone through to get to sitting with you. To start to tell their story. So an important thing to remember is that we send messages with our body, as you all know, and your voices and how we frame questions all the time. So being really aware of that when you're asking these questions. I mentioned earlier, my anxiety often presents as, oh, I got to do this right, and some more rigidity, and then writing things down. That can be picked up on by other people as well. And so leaning into the person, really looking at them in their eyes. And these are things that you all know, but really important to remember, because often without us knowing, if we are doing something for the first time or something that we're uncomfortable with, we show it in our body. So being mindful and aware of that when we're asking these questions. And then, of course, safety assessments come up a lot and is something to think about. And we want to be thinking about not jumping into those too early as well, which is something that we'll be talking about in a moment as well.
okay, so here's a segment about similar theme. We're continuing our learning. So about voices. So some common statements. People shouldn't hear voices. I need to jump to assessing risk, danger, and need for hospitalization, assessing risk and danger. This person can't make choices to keep themselves safe. So yeah, I want to talk about voices and visions and other kinds of experiences of this nature. Um, so, yeah, I think, we talked about this in the last slide too, but developing and cultivating like genuine concern and understanding. I think, there's an interesting notion in writing that I found to be really helpful in understanding mental health experiences, and or just life. It's like understand, don't judge. So, you know, in Buddhism too, it's like keep learning and moving and growing towards understanding. And then when you think you have understanding, to keep cultivating understanding. And like there's a lot of peacefulness and there's a lot of intelligence in this too. You know, so I think I've dealt with voices, I've dealt with visions, you know, there are a number of different ways to look at it, a number of different understandings. I think, you know, one of the major things to be aware of is that like voices aren't always necessarily dangerous. Some people welcome them. People can have voices in their lives and still know how to manage them. I'm a part of the Hearing Voices Network. I've coordinated 2 groups, one for 6.5 years, another for 4 years. We're still going. And yeah, there are just so many understandings of hearing voices that can be available and a number of different perceptions too. So I think something for us to be aware of is that like, you know, in like person first care, like really taking good care of the person. So like what's going to help this person? What's going to help them to learn and grow, you know, and have the life they want, be the person they want to be. So we talk about like, you know, some ideas are responding with compassion and not making assumptions about people, you know, catching those assumptions. Or there's also the idea of holding our ideas lightly. So like when a reflection is given really lightly, you know, we talk about the spirit of MI, but beyond the spirit of MI, you know, I know there's like person-centered, but like freedom is a human right. I think it goes beyond like the psychological constructs we have. Like someone's freedom is their human right. So also the idea it's their right to decide what they think and feel and want to think and feel, and we don't want to decide that for them. So to really respond like with curiosity, with softness, so someone can decide for themselves. You'll make mistakes in your reflections. They'll be able to disagree with you if you put it lightly. The times that you'll probably get a stronger kind of rebuke is if you put things as a fact or they're stated heavily or it's like a have to or a must. There's this idea of like dwelling in possibility. Emily Dickinson, it's from one of her poems, but I really like this as an idea when I'm meeting with people. I use a lot of possibility words. I don't want to use certainty words, just kind of flowing through the conversation, letting people decide what they think and feel. I'm not, you know, I'm not bound to what anyone thinks and feels. So, asking about how these experiences impact someone and what are their concerns and what are the things they're concerned about. It might not be the voices or the visions. It might be, I haven't eaten in 3 days. It might be, I just, you know, went through a really traumatic experience. I just lost all my friends. You know, things in someone's life are the things they're typically usually really concerned about first.
Now we're going to jump into specific guides for asking these questions, and then we'll do the role play. So we've talked a lot about biased thoughts or just different ways we think about things and how that can impact how we ask questions. We might be asking ourselves, what are questions that I can ask if someone might be starting to say that they're having these different experiences of psychosis or altered states. So I really want to highlight and direct you to this amazing website that a lot of the MapNet folks and some primary care folks put together. Some of these people are on the call today. So it's the psychosisscreening.org. It's wonderful. It has examples. It has thoughtful guides, has specific questions, and it also has really nice flow charts of when you're hearing different symptoms or people are asking for different help, different levels of care that you might consider helping them think about or get connected to. So I highly encourage you to check this out. And the guides that we wanted to walk you through are directly taken from that and informed by that. So when you're thinking about screening for psychosis or helping someone be able to name their psychosis experiences, it's helpful to think about these 3 different categories of asking questions around what is the experience like, how is it impacting them, and how often has it happened and has it changed or progressed in some ways. But really using all of the information that we just talked about of informing how you're asking these questions as well, not doing it from a checkbox perspective, but really from a humanistic perspective of meeting that person where they're at and understanding what they're looking for in terms of help and what they're concerned by. So I'm going to just breeze through these really quickly. So examples of ways of asking about what this experience is like is, can you tell me more about that experience? What do you make of it? Why do you think that's happening? How so? Again, these are open-ended questions, not close-ended questions like you're going to see in the role play. Okay. And how is this experience impacting them, or is it impacting them at all? Really non-judgmentally keeping that open-minded. What do you make of that happening? Do you ever do anything differently because of it? How do you feel when that happens? Does it ever bother you? Again, not assuming that it bothers you. So a common mistake or misstep that I made in the beginning is, someone describing hearing voices. And this is an example that Steve just brought up and saying, oh, that must be really difficult for you. There I'm making an assumption that that is difficult for that person, but maybe it isn't. So what is that like for them? What is that like for you? Opens that question up more. And then asking different questions around how often is it happening, and how has it changed over time as well. So I rushed through that, but you can find more information on the website, which is really wonderful, and I encourage you all to check that out. All right, so with that in mind, we're going to do 2 different role plays. One of them is going to be some missteps, and then the next one is going to be based off of the recommendations and tips that we shared as well. So for this role play, we're imagining that this is the person's second session. They've already met, Divya's already met with you once, and it's the very beginning of the session.
It's nice to see you again.
Yeah, you too.
How are you doing today?
I'm okay. Yeah, I just feel a little out of it. I haven't really been sleeping, and I haven't eaten yet today, so just out of it.
Well, you're not sleeping or eating.
Yeah.
Well, that's concerning. Those things are really important. What's making that difficult for you?
Yeah, I don't know. A lot's just been going on.
What's been going on?
Well, I told you last week I started school this week, so that's just thrown my schedule around, and yeah, I haven't had time to meal prep.
Okay. You told me you started school, but you didn't tell me about the eating and sleeping. You said something about meal prep.
I feel better if I make food that I've made myself, so like if I haven't made it, I don't trust it.
You only eat stuff that you make.
Yeah.
Why?
I don't know.
Well, it seems like an important question, since food is so important. So why would you be uncomfortable if someone else made your food?
I mean, just like I said, I just don't trust it.
Are you worried it's tampered with, that it could be poisoned, that something might be wrong with it?
Maybe.
That's sounding like it could be paranoia, which I'm pretty worried about. And
I mean, I don't think I would call it paranoia.
It's sounding like paranoia. Worried that someone might be poisoning your food. So I want to ask you some more questions about, but I'm also really worried about the sleep too. What's wrong with the sleep? Why is it hard for you to sleep?
I mean, that's also confusing. I don't know. I don't really, it's just a lot going on.
Okay. Well, I'm having a really hard time following you. So what happens at night?
It's like there's like noise, or I don't know, maybe feedback at night. I don't know if I'm getting maybe.
What do you mean by feedback?
I don't know. I don't really know how to describe it. It's like yesterday, for a second, it almost sounded like my stepfather, but I don't.
Your stepfather?
Maybe, I don't know.
You live alone, right?
Yeah. I've just moved to an apartment, like I said, last week.
Right. So you heard your stepfather's voice even though he wasn't there. Are you hearing other voices?
No.
Are the voices telling you to hurt yourself?
No.
What about other people?
No, it's nothing like that. I don't even know if it's a voice.
So you're not feeling unsafe?
No.
Okay. I really need to ask you some more questions to make sure that I'm the right person to help you.
Why wouldn't you be the right person?
Well, we can talk about that at the end, but I need to make sure that I understand your symptoms and that I'm the right fit for you.
I mean, I don't know. I really just want to talk about school. Like I told you when I first started seeing you, I just want to do well in my classes.
Yeah, I mean, I hear that, but if you're having paranoia about, and it's making you so that you're not eating, and if you're also not sleeping because you're hearing this this feedback and the voices, I really don't think school is a good fit for you right now. I think you need to take a break and really focus on getting help for these symptoms.
Yeah, I don't want to talk about this anymore. I don't think this is helpful.
It's nice to see you again.
Yeah, you too.
How are you doing today?
I'm okay. Yeah, I just feel a little out of it. I haven't really been sleeping, and I haven't eaten yet today, so just out of it. Spacey.
Oh, I'm so sorry to hear that. Thank you for still coming in today, even though it sounds like you've had a hard morning.
Yeah, of course.
Yeah. Can you tell me a little bit more about how that has been for you?
It's been okay. It's I don't know. I mean, I told you I started school, so it's just a lot at once going on.
Yeah, that's a lot to be balancing. Starting school, I know you moved into your own apartment and trying to balancing making your own food. That can be a lot.
Yeah, it's a lot.
Yeah, I can imagine so. What makes it challenging to eat in that context?
I think just because everything is new and my schedule's new, I haven't really had time to meal prep the way I normally like to. And I mostly eat food that I make myself. So actually, I don't eat any food that I don't make myself.
Okay.
It feels more comfortable, and I don't like to buy food out.
Okay. Yeah, comfort is really important. What makes it uncomfortable to buy food out?
I don't really know how to describe it. I feel more comfortable when I can like see everything that went into it, and I just trust my own food more.
Yeah, so trust feels important, and it's difficult to trust food that you haven't made.
I guess, yeah.
Yeah. And how long has this been coming up for you, only trusting food that you prepare yourself?
I don't know, a little bit, but this last week I've been pretty stressed about it.
Okay. Yeah. Well, I'm curious about how that's impacting you and also to learn more about the sleep. But before we jump into more of those questions, how is this feeling for you? Because I know that you're not feeling your best today.
I mean, it feels okay.
Yeah.
Yeah.
Okay, good. Well, this is your space, so we want to make sure that this is feeling comfortable for you. You don't have to answer anything that I ask you that you don't want to talk about, and we can also end early if you're not feeling up for it.
Okay, I'll let you know.
Thank you. Okay. Is there anything that you want to ask me or any questions you have before we continue on?
I don't think so.
Okay. My goal is really to understand your experiences so I can provide some support and we can brainstorm together what would feel the most helpful for you.
Okay.
All right, so we talked a little bit about what's making eating challenging for you. How about sleep? What's making that challenging?
I don't know. I don't really know how to describe it. It's kind of confusing.
Yeah, sounds confusing. Is this the first time you've talked about it with someone? Well, that says to me that it's really bothering you and that it can be hard to talk about things that we haven't talked about with other people. So I appreciate you trusting me in that.
Yeah, it's scary.
It sounds scary. Are there specific things that stand out to you that are scary for you?
Yeah. At night, there's this noise, or I don't know, maybe it's like feedback. I guess I don't really know how to describe it.
I'm following you. So, you're living alone now, but you are also hearing noises, and it sounds like feedback noise as well.
Yeah. And I don't know, it's like I almost hear it in my stepfather's voice, which that's like the freakiest part because he's obviously not there. So I don't get why that's happening.
Wow. Okay.
Yeah.
Yeah. How was that for you?
It was scary.
Yeah, I can imagine.
Yeah.
How has that fear been impacting you?
Well, it's just hard to do anything when I'm not able to sleep at night. It's really hard to pay attention, like in school, and that worries me that I'm going to do poorly because of that.
Yeah.
The semester is really important.
I know how important school is to you. We talked a lot about that last time, and it really sounds like things are harder for you right now with having difficulty eating and the sleep difficulty as well. Would you like to think together on possible ways that we can help support you and so that you can continue to show up in the way you want to show up at class?
Yeah. Okay.
Okay.
one of the themes today is to, just continuing develop awareness and working on internal stigma and bias. We're all working on this. I think everyone everywhere, myself included, I have things I'm working on too. So yeah, we're all here together to just learn and grow and to keep learning. And yeah, so that's one of our themes.
Another one, hopefully we can empower you to really use the skills that you already have, your compassion, your humanness, and build off of that, not feeling like you really have to recreate the wheel, and to integrate all this information to help you feel comfortable in asking these questions and working with individuals who are walking through your door.
Yeah, our third focus is human to human connection. The same way you'd connect to a friend or a family member, but you can do this, right? Like you can do this and still observe the space and still observe the construct that like we're not making friends or we're not someone's family member, but like, yeah, connecting and just genuinely caring about them as the person they are and wanting to see them have a good life.
And always keep growing and learning. That's what we're all here to do and support each other.
Just want to thank everybody for attending today, and a huge thank you to Emily, Steve, and Divya for your presentation and your thoughtfulness, and look forward to seeing you all soon. Take care.